Hi there, I'm your host, John Ivison, and today I'm joined by the Federal Health Minister, Jean-Yves Duclos, to talk about the state of Canada's health system. Welcome, Minister Duclos.
Hello, John, and thank you for the invitation.
Well, thanks for taking the time to chat. I know you've had a busy week. So the word crisis is bandied about quite freely in politics, but I think it seems appropriate in this case that there is a crisis in the health system. We've obviously got overcrowded emergency rooms, people talking about 20-hour waits, understaffed hospitals, hallway medication, and so on and so on. And yet, when you met with provincial health ministers this week, which seems to be the kind of longest running production in Canadian politics, federal and provincial ministers pointing the finger at one another. It blocked a deal that I think you thought you had, that might have seen new funding come into the system. And while you don't strike me as an angry kind of person, you did seem to be genuinely outraged by what happened. So what did happen?
Well, thank you. And let me explain that in three different steps. First, I have, and I think we have as health ministers, a great, but more importantly, an important positive relationship together. And that has been the same, that way for many months now, and in fact many years, at least since COVID-19. The second thing is that over the last few months, some of my colleagues, health ministers, took the leadership, and that was great, to propose to the federal government and other colleagues two plans. One on health workers, called Human Healthy Resources, and then the second plan was for the better use of data to improve the quality and the safety of care for Canadians. And those two plans were advancing really well, and we were supposed to approve of them and to put them into place after the conference last week. Now, the third thing is, unfortunately, a few days before that conference took place in Vancouver, premiers sent my health minister's colleagues marching orders to stop that progress and to make sure that we wouldn't communicate to Canadians those two great plans that we had worked on so well over the last few months. So that made me obviously very disappointed and a bit angry, because this is important, John. Now we're talking about the health of millions of Canadians who are fearing that if they fall ill, they are not going to access, for instance, a family doctor, that if they were to be ill, if they went to an emergency department, it would take hours and sometimes days for them to get the care that they would need. They don't particularly enjoy the view that there are serious delays in surgeries and diagnostics. So that's unfortunate and made me somewhat angry, but I think made my colleagues, health ministers, also not very happy. But they were under marching orders not to get to those agreements by their premiers.
They did look very sheepish when they announced in a press conference, which I guess you were meant to be at, that there was no deal. So you did seem to put some water in your wine as far as the deal that was on offer, in that there would be more federal funding if the provinces agreed to share data. And I think, correct me if I'm wrong, but previously you were insisting on better results as a condition for more funding. So are all provinces on side with this idea? It would seem to be that Quebec would not like the strings attached of having to provide more data, which might then be used against it if the results weren't very good.
So let me clarify two things. So there are two streams of funding which I announced we're willing to provide. The first one is on results. So separate funding targeted to those priorities that all health ministers agree on, including better access to family doctors, greater access to mental health care, better measures to protect and to maintain in their job health workers, reducing surgery. So those dollars would come from the stream of achieving the results that you mentioned. Those are important results for Canadians. The second stream is indeed related to Canada Health Transfer, and we said that we would be willing to increase it if we were all willing to better use data to improve the quality of care to people, including the safety of care to people. Because we're in 2022, John, it's not normal that we still use faxes and paper forms to make pharmacists work with physicians and nurses and lab technicians. It's not only data sharing between governments, it's data sharing between health providers and also people having access to their electronic medical records. Most Canadians, a large number of Canadians want that to happen. Unfortunately, only a third of Canadians currently have access to some parts of their electronic medical records. So we want to speed up that transition, and that's why we made that as a condition to receiving additional Canada Health transfers.
And the federal government has been funding digitization of healthcare for 2 decades in the form of the Canada Health Infoway. Are there signs that it is working? Does it actually improve the quality of healthcare that Canadians are getting?
And the answer is yes. Now, let me take a simple example. In Quebec, certainly, and I know it's true elsewhere. Now, there are still patients who, when they need to go and so to the emergency department needs to carry out all sorts of tests that whose results are already known to the family physician, but because the systems don't talk to each other, the patients have to wait for hours, sometimes even longer, before the emergency department knows how to care for them. Thus, that's not only time and effort that is being wasted, but often the safety of the health and the health of those patients that are needing the care. And it's true, pharmacists don't talk to physicians because physicians still need to use faxes and paper forms to prescribe drugs. So it does all sorts of bad things which we don't have time to expand on. So again, we're in 2022. So it's not normal. We are laggards, in fact, in the G7 countries. We're behind many other industrialized countries in terms of using the value, including the safety value of better access to and sharing of data.
You mentioned in your closing press conference that the old ways are not working or don't work. The data suggests that you are right, that we're spending almost more than any other country per capita. I think only the US, Germany and the Netherlands in the OECD spend more per capita. In constant dollars, in the last 20 years, the amount we spend has doubled, and yet the results have deteriorated. Wait times to see a specialist and then get treatment have more than doubled, 6 weeks longer than physicians deem to be clinically reasonable. It doesn't seem that Canadians are getting good value for the money they spend right now.
Canadians are still very proud of and supportive of our publicly funded, universal and accessible health care system. But Canadians also know that we want to maintain that accessibility, that equity and universality around health care. We need to be mindful of the serious pressures under which this system currently is, and equally importantly, the serious pressures that are coming and have come for some time around the aging of the population, including the aging of the health workers. Many health workers are leaving, sometimes unfortunately before the normal retirement age because they are just too tired or sick because of COVID-19 and other things. So, and obviously they become older, so many of them would be leaving anyway. The young nurses find it challenging, and the young doctors too, because they enter into a world in which the usual mentorship and sponsorship that they would benefit from is more difficult to have because the older nurses have left or leaving. So they find it more challenging to integrate their profession and to find themselves at ease and safe in procuring care to their patients. So most Canadians understand that, and my health ministers understand that too. So that's why the old way of doing things would be to send dollars to finance ministers and hope perhaps that those dollars sent to finance ministers would make the system change and would provide support to my health minister's colleague to make that change. That old way of doing is not working anymore and wouldn't work with the new pressures that we're seeing forward.
So if the outcomes are not optimal, shouldn't we be experimenting more with private provision, albeit within a system where universal access is paramount?
Well, there is obviously a significant private part of the provision of healthcare in Canada. Family physicians and physicians in general have been self-employed workers essentially for the last 50 or so years. So it's already there, and there might be ways to make might be ways, I'm careful because there might be ways to continue to support our publicly funded and accessible and universal healthcare system with such support. But let's be also very clear. What nurses are telling me is that when nurses leave the profession and go and become agency nurses in the private sector, what happens then is that, obviously they do that because they would be paid more in some cases, but more importantly, they'll have better work conditions, a more stable work agenda. They wouldn't need to work and forced to work during the weekend or at night and the evening. They wouldn't need they wouldn't be forced to stay overtime. So when then these nurses leave and go and work for private agencies, the public nurses that remain, their workload is increased even more because they have to fill those schedules which normally would be shared by more nurses. And obviously the private sector is also therefore a private and profit motive, and it's not there necessarily to serve the clients, the patients that have the greatest needs, and not necessarily there either to provide the continuity and the integration of care that is so essential to support family health teams, for instance, and avoid them, as you said, going to an emergency department because they don't have access to the family health team. So there could be advantages in some contexts, but there are also some serious challenges and risk to overly using the private sector, because it does tend to weaken the public sector as this is happening.
Just returning to the premiers and their demands. I mean, I presume you don't accept their line that the federal government is only paying 22% of healthcare, and they want 35%, which would essentially require you to write a cheque for somewhere around $30 billion. There's not much slack in the fiscal framework right now. We saw that in the fall statement last week. Should the premiers temper their expectations?
Well, let me be clear first on the 22% and 35%. I'm an economist, so I like numbers and I like budgets. The 35% number makes sense if you understand how it has been developed. It was developed in 1977 when, at that time, it was decided that the value of the federal government's support to provinces and territories would be the cash transfer, called the CHT, plus the dollar value of the tax point transfer. So that's the way to understand 35%. Now, if you speak about a number, you need to define what that number means in the first place. So when you understand appropriately, which premiers don't seem to do, the 35% definition is the sum of CHT and tax points. But that has been 35%, roughly speaking, for the last 40 or 50 years. It went above 35% during pandemic. It's just about 35% now. So to engage in such a fight around 35%, I would suggest is a futile fight, because we're already at 35%. We've been there for the last 50 years or so. So it's an unfortunate, futile fight, which most Canadians don't like, perhaps, except for a few economists that, like me, that understand those numbers. But what is more important is to fight for the conditions of care for our patients in Canada, and that requires speaking of results and priorities and ends before, as the Prime Minister promised, we put more dollars into a system with more results. Because if dollars were the solution, John, the provinces and territories would be able to solve our problem, because they're already on average into surpluses, and all of them, or almost all of them, will soon be in big surpluses. So if dollars were the solution to the problem, they would be able to solve that problem immediately, because they have surpluses, which the federal government obviously doesn't have.
And I did ask you about Quebec. Is Quebec on side with that if the premiers agree? So
I'm a Quebec minister. I have the fortune of understanding the local politics. I would say that Quebecers agree on the same things that other Canadians agree as well. We have the same healthcare system, we have the same aging of the population, the same diseases, including chronic diseases. So it's in the same challenge around the organization of healthcare. So it's all very similar. The politics is slightly different, obviously, but we're facing the same priorities and want to put into place the same solutions.
Just to wrap up, you concluded by saying in your press conference on Tuesday that you are optimistic about the health system. There don't seem to be that many grounds for optimism. Why are you optimistic?
I'm optimistic because at my level, with health ministers and with all the key stakeholders, the key partners, the medical associations, the nursing unions, the nursing associations, those representing the interests of patients, all of those experts from academia and from think tanks, everyone agrees on what we need to do together. So I'm very, very positive and optimistic on that. We just need to let these people do their work and avoid the bickering and the fighting that happened at the premier's level on trying to focus only on dollars, because as we've said all along during this conversation, dollars won't solve the problem. We need to do things better and in a different way.
Thanks very much for your time.
Thank you, John.